Bone and joint management after cardiac surgery. Bone and joint problems are frequent after cardiac surgery, and we will discuss a few of them today. Most important is osteoarthritis. It's a degenerative joint disease. It's a chronic process and slowly progressive, and there is a loss of articular cartilage which causes increasing in pain, and there may be minimal or absent inflammation. It is caused by increasing age and trauma, and most commonly in weight-bearing joint. Can involve any joint, but proximal interphalangeal joint and metacarpophalangeal joints are commonly involved, and you will feel a crepitation in those joints. Laboratory investigations, ESR would be raised. They can have anti-nuclear antibodies, and rheumatoid factors can be tested in these conditions. And X-ray shows joint space narrowing, osteophyte, and subchondral sclerosis and bone cyst. Treatment includes weight loss, moderate exercise, and of course analgesic in the acute phase, and intra-articular steroids if the pain is worse, and further management by the orthopedic people. Other common condition is gout. It's an arthritis which is caused by urate metabolism, and it could be due to overproduction or like idiopathic or increased turnover of the cells, and enzyme deficiencies like Leishman syndrome, glycogen storage disease, or under secretion of urates such as renal insufficiency, ketoacidosis, lactic acidosis, thiazides, and aspirin. And usually present with sudden excruciating pain, redness, tenderness of the big toe. Patient can have fever. Gout could be chronic, and in such case there will be tophi and uric acid stones. And the diagnostic test is aspiration of the joint, and which shows needle-shaped crystals, which could be done by the orthopedic team and or the rheumatologist. And we can check uric acid levels. X-rays are normal in early disease but show erosion. Acute attack is treated with non-steroidals. Corticosteroid can be given, and colchicine can be used. Chronic disease, the management including diet, decreased consumption of alcohol, lose some weight, and decrease high purine foods such as meat and seafood. Should not use thiazide, aspirin, and niacin. Colchicine is effective in the management of chronic condition. Allopurinol is also used. Probenecid and sulfapyranozone increases the excretion of uric acid. Pseudogout is caused by deposition of calcium pyrophosphate. It differs from the gout in that the large joints such as knee and wrist are affected, but not particularly first MCP, and DIP and PIPs are not affected. Diagnostic test, uric acid are normal. X-ray shows calcification of the cartilaginous joint structures, and the treatment is analgesics, intra-articular steroids, and colchicine. Low back pain is a common scenario, and it's very common in elderly patients. A patient may have a lumbosacral pain, strain, and could be taking non-steroidal anti-inflammatory drugs. Now, the low back pain, the thing which we need to concern about is the compression of the spinal cord, which might occur in the presence of malignancy or infection, and look for the history of cancer and focal neurological deficit and see if there is a sensory level. Point tenderness along the spine should be elicited, and if percussion, point tenderness with the percussion is highly suggestive of cord compression. Hyperreflexia can be found below the level of the compression. Epidural abscess is common from Staph aureus, and it can present at the same way as the cord compression from cancer, but there is high fever and marked raise in ESR. Other common condition is sciatica due to disc herniation, commonly L5 and S1, and a straight leg raise is positive. So a negative SLR excludes the herniation in 95% of the sensitivity. So the diagnostic test for low back pain is it requires to rule out the cord compression, epidural abscess, ankylosing spondylitis, and caudate venous syndrome. Most importantly, it's the MRI scan. CT scan is used as it's common when in cardiac patient if we can't do MRI, as if the patient has the pacemaker. If CT scan is used, then we can use the intrathecal contrast also. If there is a cord compression, then the treatment is glucocorticoids. If it is due to cancer like lymphoma, then chemotherapy or radiotherapy for solid tumors. Surgical decompression if the steroids and radiation ineffective. Epidural abscess steroids are used to control the neurological deficit. Antibiotics such as vancomycin, linezolid can be used, and for if the sensitive staph is formed, then oxacillin, nafcillin, cefazolin can be used. Caudate venous syndrome needs surgical decompression, disc herniation, analgesics, and continuation of the ordinary activity. Steroids can also be used. Lumbar spinal stenosis is narrowing of the spinal canal due to pressure on the cord. It's idiopathic. Pain occurs when the back is in extension or the cord presses backward against ligamentum flavum. And the pain is worse when walking downhill and better when sitting. Pain is much less with the activities that have patient leaning forward, such as cycling. It is diagnosed by MRI and treated by analgesics, and surgical correction is needed to dilate the spinal canal. Fibromyalgia is common in a young patient, and tenderness along the trigger point and focal tenderness along trapezius. Pain occurs at many sites, stiffness, numbness, headaches, and there may be sleep disorder. All lab tests are normal. ESR, CRP, rheumatoid factor, and CPK levels. Initial therapy is amitriptyline, pregabalin, and tender point injection, and we can give exercise. Carpal tunnel syndrome is common after surgery. If the patient has retained water due to fluid therapy, then obviously it can aggravate the carpal tunnel syndrome. And it's a peripheral neuropathy from compression of median nerve which passes on the flexor retinaculum. Other causes that can cause carpal tunnel syndrome including pregnancy, diabetes, rheumatoid arthritis, acromegaly, amyloidosis, and hypothyroidism. And tapping and percussion over the median nerve elicit the pain and tingling, and flexion of the wrist can also produce the symptom. We can perform electromyography and do nerve conduction studies to diagnose this condition, and wrist should be splinted and avoid manual surgery. Rheumatoid arthritis is an autoimmune disorder predominantly of the joints with many systemic manifestations. It's a symmetrical joint involvement, morning stiffness more than 30 minutes, and rheumatoid nodules may be present, and there could be lung involvement which could give rise to pleural effusion and nodules on the pulmonary parenchyma, which can give a challenge in the post-operative cardiac patients, and cervical joint involvement which could give difficulty during intubation. Baker's cyst can be present, which may mimic DVT in post-operative period and can have pericarditis and pleural diseases, so which can mimic pericardial condition. Again, rheumatoid arthritis can present with carpal tunnel syndrome, can have osteopenia and osteoporosis, which could lead to rib fractures in post-operative patients. Rheumatoid factor is positive, anti-cyclic citrullinate peptide is positive, and the radiograph may show erosion of the joint, elevation ESR and CRP. Patient would be anemic. An X-ray would be showing abnormal joint. It could be associated with Feltes syndrome, which is rheumatoid arthritis, splenomegaly and neutropenia, and Kaplan syndrome, which is rheumatoid arthritis, pneumoconiosis, and lung nodules. Treatment including methotrexate, TNF-alpha inhibitors, rituximab, hydroxychloroquine, sulfasalazine, and we should give analgesic for symptomatic control. A similar condition can be seen in younger patients, which is juvenile rheumatoid arthritis. And the diagnostic test is obviously ANA and anti-dsDNA. Treatment involves boluses of steroids. Antiphospholipid syndrome is best treated as an important topic. It's an idiopathic disorder with IgG and IgM antibodies. There are two main types, one with lupus anticoagulant and one with anticardiolipin antibodies. So they pose problems because they can cause thrombosis and the elevation of APTT. So best test is mixing study, and other specific test is lupus anticoagulant. It's a Russell Viper Venom test. So if the patient develops DVT or PE, it should be treated with heparin and warfarin. Systemic sclerosis, scleroderma. Cause is unknown. It could be a diffuse disease or it could be a limited disorder known as Crest syndrome, which means calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasias. Most commonly found in young patients and could present as Raynaud's syndrome, skin manifestation, and gastroesophageal reflux disease, hypertensive crisis, lung fibrosis. And post-operatively, they can give rise to myocardial fibrosis, pericarditis, heart block, lung disease, and right ventricular hypertrophy as well. So scleroderma is important from the cardiac surgical point of view, and we need to see ANA, ESR, SCL70, that is anti-topoisomerase antibody and anti-centromere antibody. Treatment is by methotrexate, penicillamine. If there is renal crisis, ACE inhibitors, even if the urea is elevated. Esophageal dysmotility, give PPI, and calcium channel blockers are used for Raynaud's, and cyclophosphamide improves dyspnea, and PFT in pulmonary fibrosis. Pulmonary hypertension should be treated with bosentan, sildenafil, and prostacyclin. Dermatomyositis and polymyositis. These are inflammatory myopathies with proximal muscle weakness leading to difficulty in getting up. Dermatomyositis present with malar involvement, Scholl sign, heliotrope rash, and Gotten papules. And diagnostic tests will show elevated CPK and aldolase, and we can do muscle biopsy. Antigen antibodies are tested with lung fibrosis. Treatment including steroid, methotrexate, azathioprine, intravenous immunoglobulin, myclophenolate, and hydrochloroquine. Sjogren syndrome is an idiopathic autoimmune disorder secondary to antibodies predominantly against lacrimal duct and salivary gland. Could be associated with rheumatoid arthritis, SLE, primary biliary cirrhosis, polymyositis, Hashimoto's thyroiditis. Presents with the dryness of the mouth and keratoconjunctivitis. Seeker need to drink water constantly and can develop dental caries. They can also manifest as pancreatitis, lung disease, renal tubular acidosis, and vasculitis. Diagnostic test is Schimmer's test, in which filter paper is placed against the eye, or we can do a lip or parotid gland biopsy. The initial therapy is hydration of mouth, fluoride treatment, and artificial tear. Pilocarpine can also be used. The cause of vasculitis is unknown. Vasculitis, as for example polyarthritis nodosa, Wegener's granulomatosis, Churg-Strauss syndrome, they give fever, malaise, weight loss, arthralgia, and myalgia. Polyarthritis nodosa is a disease of small and medium-sized arteries. It spares the lung. It's difficult to identify. Common features are in kidney, it can give rise to glomerulonephritis, and any large peripheral nerve can be involved. Peroneal neuropathy or foot drop can present, and could present as a stroke in young women. Gastrointestinal abdominal pain is worsened by eating. Skin lower extremity ulcer are most common, can give rise to livedo reticularis or mononeuritis multiplex. Diagnostic test is biopsy, angiography, and look for anemia, leukocytosis. Treatment is prednisolone, cyclophosphamide. Polymyalgia rheumatica, elevated ESR, and steroids are used. Giant cell arthritis against visual symptoms and jaw claudication, treat with high ESR and treated with prednisolone. Wegener's granulomatosis, there is combination of upper and lower respiratory tract symptoms with renal insufficiency, sinusitis, otitis media, mastocytitis, and treatment is prednisolone and cyclophosphamide. Churg-Strauss present with asthma and eosinophilia. Inoxion in purpura, there is gastrointestinal pain and bleeding. Skin shows purpura, joint shows arthralgia, and there might be hematuria. Treatment is again steroid. Seronegative spondyloarthropathies are of three types: ankylosing spondylitis, psoriatic arthritis, and reactive arthritis or Rheumatoid syndrome. And there is involvement of the spine, negative rheumatoid factor, enthesopathy, and uveitis. HLA-B27 is positive. Ankylosing spondylitis, backache and stiffness, and decreased chest expansion, and transient arthritis with atrioventricular block and uveitis. X-ray of the sacroiliac joint should be done, and MRI can be done. Psoriatic arthritis, sausage-shaped digits, and nail pitting. And diagnostic test, X-ray showing pencil in a cup deformity. Treatment is non-steroidals and methotrexate. Anti-TNF alpha agent can also be used. Reactive arthritis, Rheumatoid syndrome, is secondary to inflammatory bowel disease, and it's a sexually transmitted infection. So we should look for joint pain, ocular finding, and genital abnormalities. And treatment is with non-steroidal anti-inflammatory drugs. Osteoporosis is a disease of older person. DEXA scanning is used for diagnosis. Treatment is vitamin D, bisphosphonate, estrogen replacement, raloxifene, and nasal calcium spray can also be used. Septic arthritis is infection of any kind in the joint space and relatively rare in undamaged joints and presents with red, warm, immobile joint. X-ray and CT scan should be done. Leukocytosis of more than 50,000 cells, predominantly neutrophilic, gram stain positive. Synovial culture is can be positive, and blood cultures can be positive as well. Treatment is via ceftriaxone and gentamicin. Gonococcal arthritis is a polyarticular disease of STD. There is tenosynovitis and petechial rash. And in order to reach the maximum sensitivity, other sites should be cultured, such as pharynx, rectum, urethra, and cervix. Treatment is ceftriaxone, cefotaxime, and ceftizidine. Osteomyelitis is an infection of bone and joint, and children are commonly affected. And diabetic patient can present with an ulcer from peripheral neuropathy, and there may be a prurient sinus tract. Treatment, it takes weeks to progress, and one should obtain a biopsy, and sensitive staphylococci are best treated with oxacillin, cefazolin, and nefcillin. It is essential to confirm the sensitivity of organism prior to treating with ciprofloxacin. Vancomycin and linezolid could also be used. And if fluoroquinolones are used, then obviously there are chances of Achilles tendon rupture, and it is contraindicated in pregnancy and young children, as they can interfere with the bone growth. So the other problems is like Takayasu arthritis. It's a vasculitis that occurs most commonly in Asian young women, and the symptoms include fever, arthritis, weight loss, and later can have arterio-occlusive symptoms, blood pressure, and pulse deficit. CT-MRI can reveal aneurysm formation and luminal narrowing, and treatment includes systemic glucocorticoids. Thank you.